So good afternoon, everyone, and I am here as Cecile Hunt, the team lead for the Transformers, and we have decided to introduce ourselves as all of the different team members come up. And so we have an opportunity to present to you a report out on the reduction of readmissions of mental health inpatients. And we want to reduce their readmissions, so that is defined as those who are within 30 days of their readmission. And so you will hear in a moment from Johan around the data that led us to identify that as an area of concern. I do want to profile that we had the privilege and the opportunity, but most of all a privilege, to be on the inpatient mental health unit where those patients, their families and the staff welcomed us into their world. And so I do think that we need to say that at the beginning of this session, that it was an important time. So you have in front of you the target progress sheet, and I'd like to focus in on 3 areas. Our lead time. So that was from the decision to discharge, and we hope to reduce that time frame. We also wanted to focus in on our quality. In our pre-work, we found that of all of the forms that were needed for discharge, some of them were not thoroughly completed, and we would have said that we had 100% defect. And we wanted to also focus in on the cycle time, the time that nurses were taking to prepare for discharge.
Good afternoon, I'm Johan, one of the managers in IT and the sub-team lead for this RPIW. So our value stream map, as you can see here, our project is just focusing on the discharge planning. However, for us to understand the whole process, we observe when the patient has been admitted till the patient has been discharged. We have a few starbursts here, but we focus on 3: documentation, because there were multiple documentation. The second one is the lack of multidisciplinary team, and also the third one is the 5S, which led us to our sub-teams. Here's a time observation form, which gave us more ideas on the cycle time for each process for discharge planning. Our takt time is 315 minutes. With our takt time, as you can see here, we focused on discharge planning that, next please, that the cycle time is way under the takt time. We do recognize that this may mean that we are not spending more time with our patient or giving more time to see them. And based from our data, we have calculated the average of patient stay is 13 days. We also gathered data from Kai-Hai, and one of the graphs here will show you that most of our patients are from this health region, but a big bulk is from Kelsey Trail as well. For our readmissions, we have a big percentage as well, like 57 out of 477 admissions in mental health. That has been readmissions. We have also checked on the discharge disposition of patient, of what type of support do they need when they leave the hospital. Last but not the least, that's it, and I'll be giving the mic to our chat.
Hi, my name is Jack Taylor. I'm one of the mental health approved homes. The first you'll see is the idea summary sheet, and the problem area was group homes were providing care to patients that required a higher level of care. The problem area of improvement was through the support and the goals and expectations of the patient. They've been addressed, which in turn would lower the readmission rates. The idea summary sheet 2, before discharge planning, was basically between the patient and the psychiatrist. After the improvement, the patient had met and been part of the multidisciplinary team twice. So therefore, the team, including the patient and all those involved, would meet all, or try to meet all expectations and dealing with this in turnovers in readmission. The team multidisciplinary coordination goal was to improve the discharge process, including the health professionals, the patient, the family, the caregivers, and all providers. By the end of the week, an inclusive discharge process has been tested and documented through standards.
Hello.
Yeah.
My name is Sheila McLeod. I'm the patient care coordinator for the mental health inpatient unit. This has been a wonderful, wonderful experience. So before, when a client came to the ward, I or the patient care coordinator would check to see if there were placement issues. If not, I wouldn't get too involved. However, later at times, we would realize at discharge, the client could not return home, and this created chaos on discharge planning and last-minute new placement attempts. Now, the patient care coordinator is to meet with all the clients all the time and double-check for sure with family and caregivers to know when they're going, if they're going, and if our information on the file is correct. Then we take the appropriate path from there. So we created a couple of work standards. So first of all, we have the discharge planning. So basically, I'm going to meet with the clients, family, all that, talk to them, and see if this meeting should even take place. If it should take place, it should be within 4 days of admission. We want it to take place close to admission and close to discharge as well, both times. We're going to meet on the unit with the patient, the nurse, caregiver, family members, as many identified supports from the community as possible, preferably in the afternoon, and at the most half hour, at the most. From there, I'm going to make some documents about what happened and distribute it to all the people that were there, so everyone has a copy and one to go on the file as well. So within that meeting, we'll talk about we'll have introductions, the purpose of the meeting, housing issues, finance issues, medication issues, goals after discharge, safety plans, and everything about what the client thinks about it all. And of course, lots of other questions within there depending on what goes down. So we tested this a couple of times, and after testing this, it was very evident that this was a positive and effective experience for all parties involved. Instead of just playing phone tag and running around trying to get a hold of people, we could all speak together at once. So I guess the most important thing with this, to me, and I think to a lot of people, was the pride and the empowerment on the client's face for being included. It was very special. It was very, very special to see the actual practice of the client coming first. I hope this leads us closer to breaking the barrier of mental health stigmas by giving our clients respect, a quality plan, and a much louder voice.
Hello, my name is Mike Rubin. Can you hear me okay? Yeah, I'm on the team and very much a valued part of the team. I'm sure that I've been told that, but I'm a little different.
We need you to move one way or the other.
I've just increased my value. I'm not a service provider. I'm a service consumer. My son has been stricken with a mental illness, and because we're primary caregivers, my wife and I, that makes we're consuming the services that these fine professionals are providing us. Anyway, so I'll get started. This is what we're doing here. By the way, I really did appreciate the opportunity. I was flattered when they asked for my input. But our team documentation here was to improve the discharge process through timely, clear, and complete documentation, which will be provided to patients, family, that's me, and community partners or providers. So then we went to this idea summary sheet. Generating ideas. So this particular summary sheet deals with the combining of the care documents with the discharge papers, with the original diagnosis papers, diagnosis plans I made, and link it directly to the discharge process. So instead of being loosely coupled as it was before, there's more of a direct solid link between those two processes. Okay, and this one really does the same thing. It takes 3 different documents, actually 4 different documents, and condenses them or amalgamates them into one document which serves all the same purposes. So what we're talking about here is efficiency. Thank you.
Hello, my name is Debbie Creedy. I'm one of the nurses on the unit, and Mike's a bit of a hard act to follow, but I'll do my best. I'm going to show you some of the sheets that we were using that were on the files. This first sheet here was a form that was developed actually by the staff to help with the discharge planning. And it was on every file. However, I don't think it was ever being used, either because it wasn't very useful or the staff really weren't sure how to use it. The second form is the Community Mental Health Nurse referral form that we were using. This form has been used for many years on the unit, and it would be filled out if follow-up was needed in the community. And finally, this is our discharge care plan that we were using. This is the form that would be sent home with the client or the caregiver. A lot of times the important information wasn't highlighted and wasn't easy to find on that form. And a lot of other information wasn't even included on the form. So basically what we discovered is that there was lots of bits of information being shared with lots of different people. We did some timing observations before and after the use of the new form, and we noticed there wasn't a whole significant change in the timing. But what we did notice, of course, is that the information that was provided on the new form was much more quality information. So I'm going to pass it to Michelle and she'll show you the new form.
Hi, my name is Michelle Blair. I'm a community mental health nurse. We've heard from Mike and Deb addressing the need for change and the process used to identify the concerns. Discharge documentation is a very important part of a successful relapse plan. After several drafts and collaborations with healthcare professionals and consumers, we feel that these concerns were addressed. This is the new community bridging form. Clients, caregivers, and community supports can easily identify critical discharge follow-up information. This was often missed before amongst too many papers. Simplified but thorough documentation allows more time for the nurse to discuss discharge follow-up with the client or supports and less time waiting. A standard work summary sheet was developed for 3 areas of the staff that will be handling the form, with step-by-step direction to ensure consistent training and reducing errors. A multi-skills training checklist is used to keep track of who and who hasn't been trained yet. Our goal is to have all staff trained in 2 weeks' time. It's been a pleasure to be a part of Team Transformers and improving our client care.
Hello, I'm Terry Field. I'm from the Environmental Services Department. I was on the Team 5S, and a little bit of humor that somebody from cleaning would do a cleaning project, but that's my sense of office. So we were tasked with 2 items. The first was 5S'ing the treatment room, and the second, the key management area. This picture depicts the treatment room pre-5S. You'll notice below there are cupboards and drawers. When we opened, we found some surprises, some goodies, some antiques, and lots of wasted space, space that wasn't being utilized at all. Next. This is a picture of the north wall. Very similar. The bottom cupboards were basically empty. Stuff was in there, but nobody really knew what was in there. Next. The pre-5S evaluation was performed and to a score of 2.1 on the treatment group. Next. The spaghetti diagram depicts a walking distance. So just in the recovery room, to the north of the treatment room, there were shelves on the wall, and when a treatment was being performed, the nurses would have to go back and forth to get something from the recovery room. So they were walking about approximately 42 feet. Next. For part travel, same thing. They were going back and forth into the recovery room for a distance of 21 feet for parts. Next. The next, which then led us to an idea summary sheet. Hey, why don't we move the items from the recovery room into the treatment room? Next. So this is a picture of both the west and north wall in the treatment room post 5S. If you'll notice the bottom part, we removed the drawers, removed the cupboard drawers. We put in bins, and bins have been ordered also for the top part, leading up for Kanban, hopefully in the near future. Next. The picture to the right is then again just a head-on of the west wall, and something we're very proud of now. The picture to the left is a picture of the south wall. On this wall originally there was one shelf that held a refrigerator and nothing else. Maintenance was very accommodating in installing the shelves for us, and we were able then to move all of the stock that was in the recovery room into the treatment area. Next. By doing this, we were able to then reduce the walking distance from 42 feet down to 12 feet. Parts travel distance, we were then able to reduce from 21 feet down to 7.5 feet. The post-5S evaluation score, we rated a 4.3. We thought it should be perfect, but okay, we'll take 4.3. These next graphs just show some of the reductions we were able to achieve. We achieved a 34% reduction in the number of items in the treatment room, 20% reduction in the cost of the items, and 18% reduction in the number of pieces.
Hi, my name is Debbie Kozak. I'm a ward clerk on the mental health adult unit. The picture that you see right now is what we removed from the treatment room. That's either being returned to stores or out of date and sent to third world. Next is a list and the amount, the price that each item costs. We actually returned $293 worth of stuff. This idea summary sheet is where we place our keys, and we were running into issues where keys were disappearing. There was keys that we didn't even know what they were for. This is pre-Kaizen. We had a man-down system that we didn't even use anymore. And I'm sure every key on the ward was here. The 5S, pre-5S evaluation sheet scored a 1. This is post-5S. Everything is labeled. We had a ambu bag that had to be in the nurse's station, and it was just kind of hanging from a hook, so we had a little shelf built and attached to the wall so it was easily accessible for all nurses. Post-5S evaluation, we received a 3.7 score. We did a work standard, which basically says if you take a key, put it in the exact same spot you got it from. Don't take it home. And last but not least, we trained on the key management part. We trained the staff that was on the ward that day. We didn't get to do a standard work for the treatment room because we didn't have our bins in, but we just heard today that our bins are here, so hopefully within the week and a half, we should have our treatment room set up.
So the team has done a lot of work in just 5 days, and most of our on the newspaper we have 100%. However, we do have to follow up a few items like set up in documentation and also for getting the list to the community from the community mental health nurses, so people are more aware of who are being treated. And for post Kaizen value stream map, as you can see, we only have 2 starbursts left. the documentation, and also making sure multidisciplinary is still intact. You can see as well there are two cycle process there that to incorporate multidisciplinary meetings when the patient is admitted and before the patient is discharged. This is just a sample of one of time observation form. And again, another sample of our post-guys for standard word combination sheet. And the percent load chart, you would see that we still are not reaching our tack time. However, we have started already the process to give more quality with our.
So as you would see, when we did our waste walk early in the week, we saw all of these areas of waste or defects. Throughout all of the work of these teams, when they were telling their story, they were able to actually delete a significant number of areas of waste. And so that work will continue, but that was just fantastic work. This is our target progress report sheet, and I'd like to again focus on the lead time. We know that we had a small improvement. We reduced the lead time by 3%, but this was never our intent to save lots of time. We wanted to improve the quality of that time spent with the patients. Also around defects, we were focusing on our quality. We began with not all of our discharge information completed. By the end of our week, 100% of the forms were completed, and we met our target and exceeded it. And I'd like to focus on our cycle time. We did reduce cycle time for the nurses preparing their discharge plan to when the patient was ready to leave the unit, and that was reduced by 22%. And in closing, we have very much accomplished very important work for the people we serve. We, I think, focused in on team-based discharge planning. We looked at how we could organize the treatment room in our key control area to support staff to spend more time with their patients as opposed to looking for stuff. We created a clear path for our patients in wellness with ensuring that, and the form is called Bridging to Community, and this is what we saw happen. We reduced the number of forms, very important. We don't want to have more forms coming out of this. We wanted to be able to take forms away. We opened up communication, and we raised the profile, we believe, of discharge planning. So in closing, we have lots of thank yous, but as I mentioned early, our greatest thanks goes to our mental health clients, their families, and their community providers. It was a privilege to be there. We have to thank our staff on the mental health inpatient unit, and all of those staff. There are many of those people had to stop, take time, answer our questions, and they contributed to each and every time. I also want to thank Jackie's tenants. We had Jackie with us because these folks allowed her and were brave in letting her come, and they had to test some new skills. So we can never underestimate their share in all of this. I'd like to thank our Mike and Jackie for joining us.
It was a privilege.
And we have many, many other thanks. The print shop, our maintenance folks, the health records, community mental health nurses, the mental health approved home operators. I crashed their party and did a presentation. Trudy, Dr. Hussein, Brett as sponsors. Most of all, and IT. I'm always scared to miss someone. And Gloria and Carol for their support. So we have many thanks. And Sensi, Narita, and Exco, his interpreter. Thank you very much. And our heartfelt thanks to, my heartfelt thanks to T. Good.